Okay, welcome everybody. Welcome to the first set of rounds for 2023. We are very lucky to have the team from Aurelia Soldiers Memorial Regional Sexual Assault and Domestic Violence Treatment Center joining us again today, and the Regional Center for Suspected Child Abuse and Neglect, which was added in 2005. And I will let Simone take over because she knows everybody on the team.
Thank you very much. And thank you for everyone joining us today. I would like to start with the land acknowledgement statement that we use here at Aurelia Soldiers Memorial Hospital. Aurelia Soldiers Memorial Hospital acknowledges that we are situated on the traditional territory of the Anishinaabe Nation. We would like to acknowledge the enduring presence of the First Nations, Métis and Inuit of this region, specifically the Tri-Council First Nations comprised of Beausoleil First Nation, the Chippewas of Rama, and the Chippewas of Georgina Island. We also acknowledge the Moose Deer Point First Nation, the Wata Mohawks, the Georgian Bay and Moon River Métis councils in this region. Should also be noted that the Wendat and the Haudenosaunee nations have also walked on this territory over time. Disclosures: we have no relationships with for-profit or not-for-profit organizations, and this session or program has not received financial or in-kind support. So we are, and I say we, I have some of my coworkers that have joined me today during this presentation. We are the Regional Sexual Assault Domestic Violence Treatment Center, as well as the Regional Center for Suspected Child Abuse and Neglect. And I will go more into the differences between those. And we will be going over referral information for those programs today. So I like to keep it informal. So if anyone has any questions, I don't mind if you ask in the moment, just so that we all remember the context of the question. And yeah, I like to address any information that you need or concerns that you have. So we are 4 full-time registered nurses, 3 social workers, and 8 pediatricians. We have 1 social worker with the SADVTC program. That's the Sexual Assault Domestic Violence Treatment Center part of the program. And then 2 social workers that provide counseling to children through the Regional Center for Suspected Child Abuse and Neglect. There are 8 pediatricians. They work with our program part-time. So if we have a child to see urgently, it would be the on-call pediatrician. And then the 8 pediatricians rotate, take turns doing our non-urgent medical clinics. And I will get more into those later. We are a regional program, so we are as far north as Parry Sound, far south as Bradford and Innisfil. The next program west of us is Orangeville, and the next program east of us is Peterborough. So we do cover a wide geographical region. And we are a member of the Ontario Network of Sexual Assault and Domestic Violence Treatment Centers, which is comprised of 37 centers across Ontario. So we all work together, we coordinate together so that victims across Ontario will be receiving standardized services and that we are working up to the standards set by the network. And then we will also discuss Project RISE today. That is new to our program. That is a collaboration with the Ontario Provincial Police to address intimate partner violence through counseling. So that is the social worker with the Sexual Assault Domestic Violence Treatment Center portion of our program is relatively new. She's been with us since March, and her position was made possible by the collaboration with the Ontario Provincial Police and the grant provided through that collaboration. So she assists with our clients with crisis management, community agency navigation and counseling. And she is currently getting her EMDR certification, and we'll be able to offer that to clients as well. So that is kind of the exciting news that happened for us this year. A brief history of our program. Our treatment center was founded in 1993, and that was through collaboration through the Ontario Network of Sexual Assault Centers. 1998, we began seeing domestic violence clients as well. 2002, we began to see pediatric sexual abuse clients, and in 2005, we began to see pediatric physical abuse and neglect as well, and the RCSAN Center, or the Regional Center for Suspected Child Abuse and Neglect Center, was added to our program. So we see men, women, and children who have been sexually assaulted or physically assaulted in an intimate partner relationship. And we also see children who have been physically or sexually abused. The client must consent for us to be involved. So even if the physician or the counselor or whoever wants to refer them to us, police specifically as well, even if they want them to come see us, we do have to have that conversation just to make sure that that is actually the client's choice and that is what they want to do. So we just have some stats here from different areas. I didn't add this year's stats yet. I apologize for that. So I will add them. We've already been invited back for next year, so I will make sure I add them for next year. But I believe that this is the Perry Sound over here. That was 2018, 2019. Most of our clients are from Orillia, which makes sense as that's where we are, and Barrie as well, just because that is a large urban center close to us. This is 2019, 2020. Just reviewing some reasons why people might not want to be involved with our program. Sometimes they believe that the police won't do anything about it or they can't do anything about it. So we do try and have that conversation with them. Why they have that belief, if they believe that there won't be any evidence, or if they believe that people won't believe them that it's not consensual. They might be concerned about the attitude of the justice system towards sexual assault. They might fear repercussions from the offender, or they just have shame over what's happened and they don't want to be involved with us or police or counseling or anything else. So we do try, when we are speaking with the victim, we do try to address those reasons because things are like societal wide. Obviously, they aren't where we want them to be, but they are changing. So we do try and make sure the client understands that they have options. So referral criteria to our program for sexual assault and domestic violence. Has a sexual assault occurred in the past 12 days? We can do evidence collection up to 12 days later. Or has the client been assaulted in an intimate partner situation in the past 4 days? Then we could offer them options for evidence collection and injury documentation, photography. Can they provide informed consent? This is very important because if they can't provide informed consent, they can't provide consent for us to be able to do the things we'd like to do. And then those that evidence that we would like to collect would not be admissible in court because the client has not consented for us to be able to collect that evidence. So occasionally it might be due to substance use that they can't provide consent, or it might be they don't have the mental capacity to consent and they may have an alternate power of attorney or caregiver that provides consent for them. So then we would need to get in touch with that person for us to be able to provide them the treatment options we would like to provide. So emergency medical treatment always takes priority over evidence collection. So before somebody is transferred to us from another care center, we do need to make sure that they have been medically cleared. So they may need to see the emergency physician prior to being transported to our center for things like pain, injuries, or mental health issues. Again, if they're not able to provide consent, then they shouldn't be transported to us yet. And does the client verbally agree to be referred to us? Again, it's consent-based program, so they need to provide that consent that they do actually want to come see us. Sometimes they don't want to see us in the moment, particularly when they're coming from far away. So they may agree to a follow-up call, and then we can refer them to resources in their area. So the referral process, you would contact the SADV registered nurse through on call through the OSMH switchboard. And I have the hospital number, and switchboard is extension 0. You would ask to speak to the sexual assault or domestic violence nurse on call, and then they would put you through to whoever the nurse is on call. We would have to address transportation. How would they be getting to soldiers? Or would they be coming with police or a support person? Are police involved at this time? They don't have to be involved for us to be able to provide them with options. It's just something we like to know at the time. And then sometimes it's easier for us to discuss options and treatment plans with the client over the phone before being transferred to us. So if they're out of the area, we frequently like to do that because I feel just it relieves a lot of their anxiety and lets them know that, you know, whether what we can offer is appropriate to their situation or not. If they don't fall in the criteria of an immediate referral, then we can always follow up with them and make sure they are connected with community agencies that are appropriate to their situation. Okay, so sexual assault treatment options. The number one reason why people come to see us is to do the sexual assault evidence kit. People frequently refer to that as a rape kit. However, it may not necessarily be you know, penile vaginal penetration. So it's better to keep the title open. So it's a sexual assault evidence kit. And that again is consent-based. So the client may initiate the kit and they may decide halfway through they don't want to complete the kit. Or they may get to see us and talk about it and they may change their mind. Or they might not want to do it and then talk to us and then they might decide to do it anyways. One of the things that helps people kind of make that decision to do the kit is that police do not have to be involved. If police aren't involved, we will hold the kit for up to 1 year while the client decides whether or not they would like to involve police. So there are 2 consents that come with the kit. One is for us to be able to collect that evidence from them and put it with the kit. The other is for us to be able to release that kit to police. So we can do the first consent and collect the evidence, but they don't necessarily need to sign that second consent, and that gives them more of a sense of control over the situation, that they're keeping that option open, but they don't have to use that option at this time. We also offer medications for the prevention of sexually transmitted infections, as well as HIV prevention medication. Physical exam and treatment of injuries, and sometimes depending on the injury, we may need to refer them back to our emerge if they have injuries that are out of our scope. Pregnancy testing and Plan B or ELA for pregnancy prevention. Forensic evidence collection with or without police involvement, which I spoke about under the sexual assault evidence kit. Support and crisis intervention. Referral to community agencies for counseling. And then follow-up visits and phone calls. So we offer STI testing at 6 weeks and 3 months, just to make sure that even though we're giving them the medication, that the medication has worked, and for their own peace of mind as well, that all is well and that they don't have any sexually transmitted infections. I'm just gonna pop open the chat for a minute, just see, make sure there aren't any questions. Okay, perfect. I just see that hanging out there up there in red, so I just wanted to double check, make sure I wasn't missing anything. Okay. So this is something new we've added for this year, just a few things to keep an eye out that might raise your concern that there might be somebody who's being human trafficked in your emergency department. So I did take the next few slides directly from recognizing victims of human trafficking in the pediatric emergency department. And I have referenced that down below. It's a really good article, and I highly recommend. It's not just related to pediatric population. I found as I read the article, and it has a lot of good information in there. So I do really encourage you to check that out and give that a read. It has a lot of good information in it. So victims can be difficult to identify, but there are a few red flags. They may present with a support person, and this could be a man or a woman that may speak for the patient and is reluctant to leave the side of the patient. They present as someone who is supportive and concerning, and they could be well-spoken, well-dressed, not necessarily what you would have in mind for a human trafficker, but just that they really don't want to leave the patient alone and don't want this patient to speak for themselves. The patient themselves may have vague or inconsistent answers regarding injuries and medical history. So it may be difficult to find out exactly how their injuries occurred. They may not be able to provide their address, may not have identity documents, or know what city they are in. They may present as anxious, depressed, nervous, or with a flat affect. And there was a good point in the article as well, that younger teens may actually present as quite confident, or they called it arrogant. Just that because if they are new to this, they might feel that this is still a choice that they are making, or that things are in their control and that there's no problem with their situation. So they may also present that way as well. They may be fearful of law enforcement because the trafficker may have threatened them or their family members if they do involve police. And there may be disclosures of unusually high number of sexual partners or historical unwanted pregnancies. So if trafficking is suspected, it's important to separate the trafficker from the victim and just assure them that this is standard ER practice to speak to the patient on their own. If the patient does not speak English, you need to use a trained interpreter to be able to speak with them, and avoid the use of terms such as trafficking or coercion, as they may not feel that those words apply to their situation. And ask questions in a non-judgmental and respectful way. So some things you might like to ask them: can you come and go from your home or job whenever you please? Has anyone at home or work ever physically harmed you? Have you been threatened for trying to leave your job? Is anyone forcing you to do things that you do not want to do? Do you have to ask permission to eat, sleep, or use the bathroom? Are there locks on your doors or windows that keep you from leaving? Have you ever been denied food, water, sleep, or medical care? Has anyone ever threatened your family? Has anyone taken away your identification papers or cards? Is there a history of child abuse? Sorry, so just go back to that. So again, you don't have to ask all of these questions, but these questions are, asking about trafficking situation, but in a more roundabout way, so that the person doesn't say, well, I am a victim of trafficking, but these questions can highlight some concerning areas in their situation. Specifically, the last question, is there a history of child abuse? Frequently, when children haven't found love or support at home, they go looking for it elsewhere, and then they're prime target to become a victim of a human trafficker. because it does make them more vulnerable. On physical examination, these are some red flags that you may see with a human trafficking victim. Signs of malnutrition, dehydration, exhaustion, poor general hygiene and dental disease, untreated or undiagnosed chronic disease, bruising, lacerations, bite marks, cigarette burns, areas of traumatic alopecia, having their hair pulled out. Extremities may have ligature marks or signs of physical restraint. Presence of a tattoo, particularly a name in an unusual location. They said things like under the arm or on the back of the neck where it might not be more obvious. And signs or symptoms of substance abuse. Frequently, substance abuse is how traffickers control their victims. Okay, and options. You can give us a call to review treatment options. Again, the choices for being involved with our program always remain with the patient or client. You can contact your local women's shelter. They will have resources as well. Specifically in Simcoe County, Rosewood Shelter is a hub for trafficking victims, so you can call them directly. However, there is a spree house in Parry Sound that would also be able to help you with resources. You can involve the hospital social worker because they will help you be able to do a lot of this legwork. I know emergency departments are very busy, so they may be able to help navigate a lot of those agencies and systems. And then consider admission to the psychiatric unit. Frequently they experience mental health issues or suicide ideation, and that might be somewhere that they can be safe while we get their situation sorted out and offer them some support and see if they want to access any of our resources or support. As far as our program goes, the treatment options are basically what we would offer to everybody if they wanted to do a sexual assault evidence kit, as well as sexually transmitted infection testing and offering the medications depending on what is appropriate for their situation. And then domestic assault treatment options. We do injury documentation and photography, risk assessment, safety planning, referral to a safe place, referral to community agents for support and counseling. That's usually the shelter in whatever area that they live in, or if it's not safe for them to return to that area because Simcoe County is full of small towns where everybody knows each other, potentially transferring them out of their town into another town and shelter within Simcoe County. Mental health assessment and follow up within 2 to 3 days after their initial visit. We would also, I don't have it here, but we would also refer them to our emerge if they have any injuries that need medical clearance. Then we generally stay with them and support them through that while they're being seen by the emergency physician. As far as risk assessment goes, we use the ODERA tool, which is the Ontario Domestic Assault I believe it's recidivism assessment. So the likelihood that this assailant is going to assault this this client again. So just a few tips to recognize intimate partner violence in the emergency department. Again, the article I used for this one is a Canadian article, and I believe Carrie Samsel is actually, I believe she's from Women's College. One of my coworkers might be able to correct me if I'm wrong. However, again, I highly recommend just reading the full statement because it's very good, very informative, very clear and full of good clinical advice. So again, I've left that reference there if you would like to access that. So we generally say women, but it could be a woman or a man. They may have delays in seeking care after they're injured. They may have untreated chronic medical conditions, again, with a vague or inconsistent medical history. unexplained injuries or injuries that are inconsistent with the history that they provide. Physical exam findings may include multiple injuries at various stages of healing, posterior rib fractures, defensive injuries, restraint injuries at wrists, ankles, or neck, and multiple visits for the same presentation, chronic pain syndromes, mental health concerns, and possibly substance use or substance abuse. So they talk about it in this article, but this is something that we did try to implement in our hospital a while ago, but we did come up against some barriers with that. However, we highly recommend in your own practice to practice universal screening. So it's the routine standardized screening upon presentation to the eMERGE department. It's low cost, low risk, so it's a very safe measure to implement and highly effective. And again, it's not asking, are you a victim of domestic violence, or, you know, did your partner beat you? But it's things like, do you feel safe at home? So it's more of an open question, and they will answer it how they interpret it. What do they mean by safe? Well, you know, verbal abuse may not make you feel safe at home. You're not physically at risk, but you don't necessarily feel safe. Do you feel safe in your relationship? Are you in a relationship that makes you feel scared? Are you facing any physical or emotional abuse? Do you fear for your safety? And again, if you ask these questions all the time, you become a lot more comfortable with them and how you ask them, and you will find your own way of, you know, addressing these concerns. And it doesn't hurt also to say to the person that you're speaking with, you know, we ask everybody this question. There's nothing about your situation that makes you feel that you are experiencing this, but we ask everybody because, you know, it needs to be asked so that the people feel safe to come forward, that it is relevant to. If there's a positive screen, then you can ask consent to refer to us or provide a list of local community agencies. And actually in that article I was reading, it's actually a really great thing. Instead of the triage nurse or the eMERGE physician screening the client, they have to go by a machine, and the machine asks them the question, they put in their answers. And if it's a positive screen, it's all anonymous, but it prints out a list of community resources and recommendations for that client to be able to access help. So I really like that one because it was anonymous and it was just taking care of kind of the client does it independently. So. And also, I'm not sure if your eMERGE department still has, we sent these out not long ago, the Sexual Assault Domestic Violence Treatment Center poster in the emergency department. In our hospital, we have it up right in the triage room so that when the client's being triaged, it's right there and they can see it. Or if the client presents with concerns about intimate partner violence or sexual assault, the triage nurse just has to turn to the poster and say, well, you know, we have this team and they can offer you these things. Do you want me to give them a call? So that is really handy. If it's not urgent, the client can always take a picture of the poster as well and have our information on their phone if they would like to contact us themselves. I'm just going to skip through the case studies right now, just because we have a lot of information to go through. But I also feel like I'm talking pretty quickly, so I feel like we're doing pretty good with time. I will come back to the case studies if we have time after. Oh, so we are on to the Regional Center for Suspected Child Abuse and Neglect portion of our program. And I'm just going to check in to see if.
No questions in the chat, Simone.
Okay, perfect. I'm just checking to see if our social workers have tuned in. Oh yeah, I see Sue and Krista there. Hi guys. So I'm going to start, but Sue or Krista, I might have you jump in to speak to the counseling, if that's okay. Yeah, okay, perfect. So the referral criteria for our program for under 12, so 11 and under, has the child disclosed abuse? Are they able to disclose abuse? If they're too young or if they're nonverbal, what makes us concerned that they are being abused? Was the abuse within the previous 72 hours? If it was within the previous 72 hours, it would be more of an acute visit through our emerge to see the on-call pediatrician. If it is not within the previous 72 hours, then we would most likely book them in for a clinic visit. We run our clinics every 2 weeks. The 8 pediatricians take turns seeing children in the clinics. And that's more of a well-child visit, so a head-to-toe physical exam, addressing the concerns of why they've been to see us, but not necessarily looking for any specific forensic evidence, whereas within the 72 hours, we're more likely to be looking specifically for anything that could be forensically relevant. And we would also want to know if police and/or family connections have been involved. Generally, family connections, and this is all situational as well, but generally speaking, family connections needs to be involved and needs to have interviewed the child prior to us seeing them. And again, it's contacting us the same way. You would get the on-call RN through the hospital switchboard and calling the hospital, pressing 0, and asking to speak to the RCSAN nurse on call. Again, that is the same nurse as the SADV nurse, so you can also ask for the sexual assault nurse on call, the domestic violence nurse on call as well. It's all the same person. Okay. And then for child physical abuse, this is for 15 years old and under. Has the child disclosed abuse? Or why are we concerned about physical abuse? Are there injuries that need treatment? Was the abuse within the previous 72 hours? And are police and/or family connections involved? And I'm just going to pop back over here. If they are 12 and older, it would still be referring to us the same way, except they would be seen through the adolescent adult side of our program, which is the Sexual Assault and Domestic Violence Treatment Center, as opposed to being seen by a pediatrician through the Regional Center of Suspected Child Abuse and Neglect. So it would still be the same phone number and speaking to the same nurse. So treatment options for our kiddos, possibly an acute visit through emerge if it was a recent assault, or a referral to our clinic. Both of those would include a physical exam by a pediatrician. If the assault was within 72 hours, we could do a sexual assault evidence kit. We could possibly do some blood work and diagnostic imaging, depending on the nature of the concerns. STI testing or sexually transmitted infection prophylaxis, some medications for prevention, if that's applicable, photo documentation, and a referral to one of our amazing social workers. So I'm just going to pop through. All right, I'm going to go back. Sorry, Sue or Krista, did you guys want to speak to the counseling piece? Sorry, yeah, there.
I'm Sue, and this is my coworker, Krista. We do provide counseling in our program to verified sexual or physical abuse cases, and that would mean it would need to be verified by police and/or CAS. And we usually offer short-term intervention up to around 12 sessions. And we are regional, so we travel throughout the region and provide service to the best of our ability in the region. So at different offices or at libraries, we book rooms, or if there's a barrier for the family to get to our Aurelia Center.
Awesome. Thank you so much, Sue and Krista. So again, and just for clarification, verified doesn't mean that, you know, it has already gone through the court system and that charges have been laid and proven in court. It's just that police and or family connections or child protective services believes that this has happened, even if there isn't enough evidence to get through the court system. That's correct, Sue?
Absolutely. And we try to get involved as soon as the interview is completed with CAS and or police, we get involved right away. So as Simone said, it doesn't have to be once there's conviction, because we know that's way down the road. It's just that we need to know that CAS and police have done their pieces and that they have determined that this has occurred so that we can proceed.
Awesome, thank you. So it looks like I must talk really, really fast today. It looks like I've made it to the end, so we can go back through and do some case studies. Just also to go over quickly our quality assurance measures. We do local peer review with all our pediatric cases, as well as peer reviewing them with the Toronto Sick Kids Hospital Suspected Child Abuse and Neglect Program, as well as the Ontario Network of Sexual Assault and Domestic Violence Treatment Centers, which I mentioned earlier. And then we also generally attend the Hospital for Sick Kids annual maltreatment conference as well. So I will just pop back through to the case studies. And just before we get into that, does anybody have any burning questions or something that I spoke really fast about and skimmed over? But anybody has any questions about it? All right, we will go ahead with the case studies. So I'm going to read it, and I don't know if anybody wants to unmute or if there's, I'm just going to see if there's a possibility. I'm not sure if you raise your hand, if I will see it or not. However, we can also pop your answers in the chat as well. So we'll go over the case study, and then I'll give you a few minutes to think about it, and then we will go over our recommendations for these particular cases. So there's an 18-year-old female that presents to West Parry Sound Emergency Department. She was sexually assaulted at a hotel 2.5 hours ago by 2 unknown males. She has been drinking. She is scared, alone, and she is worried about injuries. So what are the first things you'd like to consider? And what would you do? How would you approach this case? So just give you 2 minutes to think about that, and then we can have some discussion. And if you want to pop up questions or recommendations in the chat, that would be cool as well. All right, if everyone has had a minute or two to consider that, we will. So the ER physician or nurse can contact the SADVRN on call. We would want to talk about what the client would like to do in terms of options that we can provide. And if possible, we like to speak to them directly over the phone. Depending on what her injuries are, she may need medical clearance before she is transferred to Aurelia. Can she be transported to us safely? And does she want a support person with her? Is there anyone she can call, a friend or a family member, that can help support her through this process? Because it can be kind of a scary and overwhelming process. So it doesn't hurt to have somebody with her to support her that she knows and that can, help her through this process. So again, just the calling us, and if we can speak to them over the phone, we can let them know, directly what we offer. And if they have any questions, do they want to come tonight? Since this is 2.5 hours ago, our best treatment options and forensic evidence collection are within 24 hours. So if she doesn't want to come immediately, she can come first thing in the morning if this is the middle of the night. However, we would make recommendations, if she's able to not to drink or eat before she comes to see us. If she's under the influence of alcohol, it might be better if she sleeps for 3 or 4 hours before coming to see us. On the other hand, we always risk losing the client and them not coming to see us at all if they don't come immediately from your hospital to our hospital. Any questions about that case study? Anybody have any recommendations that I've missed, or any questions about our recommendations?
Hi, Simone. I just want to add, I'm
Yeah.
Olivia, the adult SADV social worker, that they can always, you don't have to go through police or the SADV RNs to see me. So you could also tell the client if they want the social worker to follow up. You guys can contact me and a referral can be completed, and then I can connect with the client at a later date. Obviously, they still have to give informed consent, so it wouldn't be that night. But that's another option as well.
So I didn't see you there before, Olivia. It's nice to see
Hiding.
you. This is Olivia. At the beginning of our presentation, I spoke about Project Rise, and that is why the wonderful Olivia has been able to join our program. And she has just taken so much off our plate, and she's able to provide the individual attention to the clients about like helping them navigate these community agencies. That's really freed us up to be able to do the more medically focused things that we do best. So yeah, Olivia, actually we will forward your referral in forms and your contact information to Kathy. And then Kathy, if you don't mind distributing that to the attendees as well. I should have thought of that earlier. So thank you, Olivia, for popping in there. That's awesome.
I can certainly do that. And just
Awesome.
so you know, there's a question in the chat box. I don't know if you see it or not.
Perfect. Yeah, I can just open that up. I think there's 2. You mentioned not eating or drinking prior to your assessment. Are there other restrictions they need to follow? So again, the not eating or drinking, that's if there is oral assault, because also I don't want anyone not to be drinking water, especially if they've had alcohol on board, they may need that. Not showering is the other important one, because that can, we can lose forensic evidence that way, and if possible, not changing their clothes. So as I'm saying more and more of these, there are reasons why people would rather just come see us immediately so they can, eat and drink. Smoking can lose oral evidence collection, take a shower and get changed into fresh clothing. Those are all reasons why they would probably want to come see us immediately, even if it's the middle of the night. However, just letting them know that, they have options. If they don't come see us immediately, it's not the, it doesn't mean they don't have any options at all. And that also, it brings up another good point, is that we can do evidence collection up to 12 days later. So if they come in at 5 days or 6 days or 7 days, they may think a week later that there's not going to be anything anyone can do. There are still options, so we can still discuss those with them. And sometimes that can be reassuring to people as well. Then the second comment, geography. Yeah, Absolutely. So that's why when we, in terms of helping transport a client down to CS, it is all, there are a lot of variables, so it is all down to the individual client that we're discussing, but we will not see somebody if they want to see us. So we will problem solve. We problem solve that as we can. So please don't think that because they have no transportation not to call us. Still call us, and we will help. Between ourselves and West Parry Sound, we can usually problem solve that. And I know time can be a big thing too, just because it is like an hour and a bit drive to start off with. So yeah, again, Esprit Place, another great great resource. So we can always contact them as well if we need help. We have before, if the client is physically unable to be transported, not very often, but we have seen clients in other hospitals, but it is preferable that we see them kind of in our own space, just forensically speaking, so that we can testify to what we have, where we provide the services in court, that it is all forensically cleaned and everything is locked up. It just makes it cleaner when we need to testify in court. So thank you for those comments. And we'll just pop on to the next one. So case study number 2, police and ambulance have brought in a 46-year-old female. They were called during a physical altercation with her current partner, resulting in the client falling downstairs and injuring her shoulder and head. Physical assessment determines her shoulder is dislocated. Her forehead has edema and bruising, as well as bruises on arms and legs. And what would you do? So I will just give you a minute or two just to think about that, and then we will go over our recommendations. Okay. So medical treatment is main priority. So she would have her medical treatment completed first, can contact the SADVRN on call, and then preferably if we can speak to them over the phone, that would be great. I don't know, did we say what time this was? So I guess this is referring to if it is in the middle of the night, she can always come the next morning to complete documentation for the assault, including injury documentation and photography. So specifically in the domestic violence situations where we are documenting injuries, if we see them within several hours of the assault, generally there might not be injuries to see. They might be reddened areas, but usually the bruising hasn't entirely come out yet. So we will see them at that time if they're already in the hospital. However, then we would like to do a follow-up visit and complete further injury documentation and photography, because we'll notice over the next 24 or 48 hours, a lot more injuries will come out, and that can be very telling in our documentation when that is presented to court. So I've contacted a family member who will assist her, and then she has involved police and they've arrested the assailant. Does anyone have any further comments on that case or questions about that case in particular? Okay, we'll pop down to our last case study, number 3. 6-year-old female is brought into the emergency department by her mother for concerns of possible fondling and penetration that may have occurred 2 weeks ago. Mom is extremely upset, and what would you do? So just let you think over the different variables of this case for a few minutes. Given the age of the client, that there are other family members involved, her mom, because when we are seeing kids, it's not just treating the client, it's treating their caregivers and support people as well. All right, let's see. So again, with this case, what are the concerns? Did the child disclose? Otherwise, why is the mom concerned that this may have happened to her child? Is family connections involved? Then we want to involve them immediately, because people will think, or clients or parents will think, that we're the ones who sort this out. It is really family connections that leads the investigation, often in collaboration with police. And I tried to explain to them that we are one small piece of that puzzle. Frequently, the medical or physical is not going to provide any evidence, but this is very important to, interview the child and see what they have to say about these concerns, because that can often be better evidence in court than a physical or medical exam. So we would talk to the RCSAN, nurse on call, or the emergency physician can page the pediatrician directly through switchboard to consult about their plan of care. So depending on the results of the history, or if they have any injuries or anything that needs documentation, we may see them emergently. In this case, it's more likely going to be a booked clinic visit after consulting with the pediatrician. And then we could also, we would want that parent's contact information to be able to discuss, why are we seeing this child 2 weeks from now in our booked clinic visit as opposed to tonight, and just alleviate some of those, just provide some reassurance and alleviate some of the worries that the parent would have. Okay. So, and particularly with children as well, there are so many different variables. It's hard to address all of them in a case study, but it really does depend on the situation, whether or not the child is able to disclose, what have they disclosed, and if they aren't able to disclose, why do we have these concerns? Does anybody have any questions about any of that, or any comments? I feel I must have spoken really, really fast because I've added about 4 or 5 slides to last year's presentation, and I'm sure we were an hour last year, so did manage to fit it all in.
If anyone has any questions, just go ahead and unmute.
Or if anybody has any questions or wants any clarification on referring to our program as well. Generally, it's just call the hospital number, press 0, ask to speak to the sexual assault nurse on call. We're on call 24 hours a day, 7 days a week. So it's usually easier to talk to us in the moment, because every situation is so different and there's so many variables that, it's better just to pick up the phone and we can chat about the concerns that you might have, and develop a plan from there.
I did repost the email for the team in the chat box if anyone has any further questions afterwards.
Awesome. Thank you, Kathy. And Kathy, is it okay if I send Olivia's contact information and her referral form directly to you and you can distribute it? Would that be easiest?
That probably is easiest, and then I
Yeah,
have it
okay.
if anyone else on our team wants it afterwards.
Or I guess they can also email us at our email address and we can send it out that way as well. We can do both of those.
Sure.
Okay.
And then I know Dr. Smith was asking about getting a copy of the poster, and I know Shannon was
Yes.
agreeable to that. I just
Perfect.
logistically, do you want to figure that out afterwards, or?
Yeah, that would be
Yeah.
fine.
Yeah, she's already emailed and we've got a plan, so
Okay, perfect.
Yeah.
You're on it.
great. Yep.
Awesome.
Thanks.
All right.
If there's no other questions, we'll wrap it up for today. Thank you very much to the team at Aurelia Soldiers Memorial Hospital. That was very well done.
No problem. We're always happy to reach out and let people know what we offer and chat about different situations. So thank you so much for inviting us, Kathy, and having us over again.
Thank you. And I look forward to next January when you come back.
All right, that sounds great. And well, I'm going to start cleaning up the presentation now. It's going to be even better next year. So come on
Perfect.
back and see us again. Awesome. Thank you, Kathy. Thank you, everyone, for coming.